Hello everyone, thank you for joining us today. My name is Barney Gill and I help with our education curriculum here at Beam Readers. I'm excited to kick off the third webinar in a series by Beam Readers oral and maxillofacial radiologists, sponsored by Vatech America. I'm honored today to be joined again by Drs. Naila Baclini and Julal Bukhari. Our goal at Beam Readers is to help you get the maximum clinical value from 3D scans you take on your patients. In turn, you can then provide the best possible care for them. Drs. Baclini and Bukhari are two of our nearly 70 oral and maxillofacial radiologists that are experts in unlocking the information within each scan. Today they will be joined by Vatech America Director of Education Jim Mayer to have a discussion on identifying and understanding CBCT artifacts, reviewing lesions, and accurately describing CBCT findings. We hope this webinar helps with your understanding of evaluating 3D image volumes and the clinical correlations. This also provides insight to the depth of knowledge and expertise that is applied to every scan we read. We're offering 1 hour of CE credit for those of you joining us live today. Please make sure you stay on for the full hour and take the survey we send following to earn the credit. Within a week, you'll receive an electronic CE certificate from me and our CE partner, Big Sky Seminars. To ensure we clearly communicate everything today, we did pre-record this webinar. Drs. Baclini, Bukhari, and Jim Mayer are here online with us now to answer questions in real time, and Jim will provide instructions on how to chat with us during the presentation. If you wish to know more, come register with us at www.beamreaders.com and see how an oral and maxillofacial radiologist can support your practice by reviewing and providing a second opinion on your CBCT scans. Also, please check out our other educational offerings on our website through the drop-down menu at the top of the page. If you have some unique educational needs relevant to CBCT, please don't hesitate to reach out to us directly at education@beamreaders.com. Now we'll get the presentation rolling.
Thank you, Mr. Barney Gill, for the introductions, and thank you all for attending. My name is Jim Mayer. I'm the Director of Education at Vatech America. It is my privilege to serve as moderator for today's session. We are truly honored to be part of and support this third radiology session in our series. Throughout the session, we encourage active participation and engagement from all attendees. Please feel free to use the chat option on your screen to share your thoughts, insights, and ask any questions. Our experts, Dr. Baclini and Dr. Bukhari, will be actively corresponding with you, providing valuable insights and addressing any questions you may have. Well, Dr. Baclini and Dr. Bukhari, I want to welcome you for today's session. Thank you for joining us, and thank you for all of your hard work you've put into this session.
Thank you very much for having us.
Yeah, and just a brief overview of what we're looking at today. We've built on, this will be our third session. So the first session we started with basic review of a scan and workflow of understanding the workflow of going through that. Session 2 was more anatomy and looking at anatomy. And now this session 3 is going to be concepts of interpretation and what are we seeing. So gaining more of an understanding of artifacts, looking at different lesions and patterns of bone and things like that. So I think we have a lot in store for everybody today. So let's look at our agenda for today. And the first thing we're going to look at is an introduction to CBCT interpretation, basically an overview of some common questions related to incidental findings. We know there's a statistic that shows, anywhere from 70 to 80% of incidental findings on scans. And doctors, what do we have in store for those specific findings, and what are we going to be talking about today?
So we're mostly going to be talking about, when we look into a CBCT volume and we're focusing on a specific pathology. First of all, we'd like to know that there is some kind of pathology there. And if there is, how can we describe it? When we describe something in radiographic terms, right? It helps us basically lead to a conclusion about something. Now, you may not be able to get to a definitive radiographic diagnosis on what this pathology is, but it can definitely narrow your differential diagnosis down, and it can help you get to an idea of what this pathology possibly could be. And so that's what we're really going to try and focus on today, the terminologies.
Perfect. I think we're starting with more artifacts that we do see in the scans, what those can be interpreted as.
Absolutely. And there's tons of artifacts out there in radiology, but for the purposes of this presentation, we're going to be focusing on two of the more common artifacts that may occur during our dental lives, basically in the clinics.
Right. Dr. Boccolini, on number 3, examining lesions from all dimensions. Tell us a little bit about, brief overview of what we're going to be talking about there.
So in this section, we're going to show the importance of looking at the lesion from the 3 orthogonal planes and the different information that we can get from each of these, of looking at the lesion from each of these planes. We're also going to focus about the importance of looking at the whole volume and how we can find, incidental findings that the provider had no idea that they were there. So this is what we're going to focus on in this section.
Perfect. And Dr. Bukhari, we've got describing CBCT findings. I know you and Dr. Boccolini are both going to be touching on this for some terminology, borders, and things. Can you just give us a little brief overview on that 4th section?
Absolutely. So again, as I mentioned, we're going to be delving into the more common terminologies that we use to describe a pathology. And when we do describe them in certain ways, we can come to a conclusion on what this pathology could be. So we're going to be delving into a few words or phrases that can help us lead to a conclusion on a certain pathology, and also assess, different bone patterns and the impact on surrounding structures, which can also help us come to a conclusion about a certain pathology.
Perfect. And then lastly, we're also going to be looking at a couple cases in the software, and we've got radiology report review, which going through what consists in the report, making sure it's concise, clear, and what the elements are within those reports themselves. So I think we're ready to begin our session today. That should give everybody an overview of the agenda, and let's go ahead and begin.
So the very first thing we're going to talk about is CBCT artifacts. Now, in radiologic terms, artifacts refer to something seen on an image that is not really supposed to be there, or we can think of it as a flaw in the image quality. And what these artifacts tend to do eventually is degrade the image quality, and as a result, they make it difficult for interpretation. Now, as I mentioned before, there's numerous types of artifacts that can be encountered in radiology. Some are related to the machinery, some can be related to the software, and some even patient-related. But for the purposes of this presentation, we'll cover 2 of the more common types of artifacts that we can come across in dentistry, and they are namely beam hardening artifacts and patient motion artifacts. So now, in order to understand a little bit more about beam hardening artifacts, we have to recognize that a primary X-ray beam is composed of photons of variable energy values. Now, this is a representation of an X-ray beam source, right? And then it is emitting a heterogeneous beam, which is reflected in the image by lines of variable thicknesses. You'll note that there's some thick and some thin lines. Now, as the beam passes through the object, lower energy photons are absorbed, and the mean energy of that beam that extends past the object has increased, in fact. In radiologic terms, we mentioned that the beam has become harder. Now, for a very specific reason, which is beyond the scope of this presentation, the subsequent beam is recorded as an error in the data set, and this data is represented as streaks on the final imaging. Now, materials that have highly absorbing properties, such as amalgam fillings, dental implants, or even metal ortho appliances, can cause such artifacts in an image. Now, if we think about it, many patients have such findings in the mouth. So this is quite a common artifact to come across. Now, let's take a look at this cropped coronal section of the maxillary and mandibular molars on a CBCT scan. We can note that the molars on both sides are restored with some kind of metal or very high density entities. And these are actually represented by metal fillings or even metal restorations, metal crowns. We can note that there are streaks right next to these crowns, and these streaks are either very bright or very dark. And these actually represent streaking artifacts or beam hardening artifacts that are originating from these metal restorations. Here's another CBCT scan. So we have an axial section of the mandibular dentition in another CBCT scan. So we can note on both sides that there are high density materials associated with the molars and the presence of multiple black and white streaks that appear to be originating from these metal restorations. Now, take a look at the overall quality of the scan. You can see that there are streaking artifacts pretty much everywhere around the scan. And what this does eventually is degrade the overall quality of the scan, specifically in this slice as well.
So with this beam hardening and streaking effects, it's important to note that this reflects horizontally in the scan. So this is another touching point on patient positioning, where we want to make sure the patient is positioned in a flat occlusion to have that streaking effect go horizontally, so it's not interfering with other parts of the data set itself. I think we're going to look at some more of that. The next thing we're going to be looking at pretty soon is maybe moving into that patient motion on there too.
Absolutely. And as a result, these types of artifacts not only degrade the overall quality of the scan, but they can also affect the interpretation of anatomic detail. So note in this cropped sagittal section of the CBCT scan that the mandibular premolar shows a dark band within the crown portion of the tooth. Now, this can be misinterpreted as a carious lesion, when this can actually represent the effects of beam hardening artifacts from the adjacent metal restoration. For this reason, CBCT imaging is suboptimal, or is considered suboptimal in the detection of caries, and intraoral imaging and clinical evaluation are still considered the first choices. So now, as the name suggests, this type of artifact is secondary to patient moving during the acquisition portion of the scan. It results in the misintegration of data and eventually appears as unsharpness on the final image, or it can be as, it can be as significant as what's shown on the image in this slide, or it can be as subtle as localized regions showing what's called the double line effect. Now, there's some methods that we as practitioners can utilize to minimize such artifacts and ensure that the image quality is good. And one of the more important things that we can do is to educate and instruct the patients to stay as still as possible during the acquisition portion of the scan. Otherwise, depending on the situation, we may have to retake the scan if we feel it's necessary. And we all want to minimize radiation exposure. There's also some machines that provide head restraints or temple supports that can stabilize the patient's head within the machine and prevent them from moving too much, therefore minimizing the possibility that the patient could move during the acquisition of the scan. James, you wanted to add something here?
Yeah, I think as from the manufacturer side, and this goes for all manufacturers, we recognize that patient movement is an issue of telling someone to hold still, in that device. So as you talked about, the temple supports, head restraints, but also a reduction in scan time, making that scan as fast as possible, but also preserving the image quality is important. So having that quick scan time also assists in, I'll say, the reduction or the minimization of having the patient move. I think that's what I wanted to add in there.
Absolutely.
I think you have one more example of like a left-right issue where the patient may have, been stable on one side, but either, moved a little bit where, it looks, you can see that distortion. I think on this next slide, we might be looking at.
Yep, and that's exactly what it is. So we're taking a look at this coronal section, focusing on the mandibular rami. And when we look at the mandibular ramus on the right side and compare it to the left side, we see that the red arrow points towards an area of unsharpness of the mandibular ramus. Now, here's where that double line effect can be properly seen. We see one line right here representing the possible position of the ramus, but also another line just adjacent to it, which shows that it could have been moving from one area, that initial area, to the other area during the acquisition of the scan. And, this is a great example of, one area which has been affected by patient motion artifacts.
The staff can also look at the data right after they've scanned. The patient is still there, and if we did see movement, then we can rescan them. I know most really all state requirements and province requirements, you're supposed to be able to see the patient as you're scanning, so you can kind of evaluate if the patient's moving or not on there.
Mm-hmm. I think it's also a good idea to ask the patient to swallow right before the acquisition, because sometimes when they swallow, it also can affect the airways and how you can visualize the patency of the airways.
I agreed 100% on that, Dr. Brown.
Yeah, very good point. It's a natural phenomenon. They're going to want to do something
I know.
during the process, so it's better to inform them prior to it.
Yeah, sure.
So again, in the end, what happens as a result of these artifacts? As we mentioned earlier, there's a degradation of the scan quality, and as a result, the interpretation of anatomic structures or even pathologies become difficult. Therefore, it's actually imperative that we understand such artifacts and try to reduce them where we can.
Yeah, so we beam hardening, streaking, and the patient movement. Something common we see in all of the scans there. So I think we're going to be moving on to the next portion of examining some lesions. Dr. Boccolini, you are going to be kind of taking us through some of this?
Yes, I'm going to be talking about the importance of looking at the lesion from different planes. I'm going to show a few cases.
Sounds great.
Okay. So this is the first case I would like to show. There's a lesion here on the sagittal view of number 18. You can see that there's a periapical lesion extending on the mesial aspect of the mesial root, and there's suspected bone loss at the furcation area. Now, when we look at the coronal view, we can see how the lesion is extending along the buccal aspect of the mesial root and how it's interrupting the alveolar crest here. So we have an endoperioral lesion. But if you look only at the sagittal view, you may not have all that information. So it's important to look and gather as much information as possible to be able to form our impression and plan an appropriate treatment plan.
Okay. So let's go ahead and look at those two screenshots. You brought up the software here. Let's go ahead and look at this within the imaging software.
Mm-hmm. So I thought we'd look at this case and go through the scan to show also to emphasize the importance of looking at the lesion from multiple dimensions. So this is a panoramic reconstruction, and we can see here on the left mandible, we can see a low density lesion around number 21. Now, if we go to the multiplanar reconstruction section, I did already align the crosshairs according to the orientation of the arch here. And I'm going to start scrolling using the red bar on the sagittal view. So let's gather as much information as we can. When we are scrolling on this section, we can mainly identify the mesiodistal and vertical extension of the lesion, which is extending approximately from the distal aspect of number 21 here to approximately the mesial or lingual aspect of number 22. We can also appreciate that the vertical extension is around the coronal 2/3 of the root. And we can see how it's causing some interruption in the alveolar crest here. However, if we only focus on this plane, we actually don't have much information on how the lesion is behaving relative to the buccal and lingual cortices. So let's go to the corrected coronal section. And I'm going to use the yellow bar here to scroll. And when we scroll, we can see how the lesion is also causing some expansion, some thinning and interruption of the buccal and lingual cortices, which may not be appreciated on the sagittal view by itself. So let's now move on to the axial view and see what information we can gather from that view. As I use the blue bar here and scroll, I can clearly see root resorption on number 22, and here on number 21. So looking at the lesion from all different planes can help us gather more information and form a more accurate impression. We don't necessarily have to have a definitive diagnosis, as Dr. Bukhari mentioned before, but at least we can rule out multiple pathologies as we analyze the behavior, the extension, and the location of the lesion. Now I'm going to show one more case. All right, so I'm going to show this case to highlight the importance of looking at the whole volume, because I received this case to analyze the lesion on number 13. There's a periapical lesion and a lateral lesion here on number 13. However, as I was scrolling towards the mesial or the medial aspect of the scan, there was an incidental finding that the provider did not really know it existed, which is this enlargement in the incisive canal. And as you can see on the coronal view and the axial view here, there is like a balloon-like expansion, which we call a hydraulic expansion in radiological terms. So we can see how it's expanding just like a balloon in a circular manner, how the cortex is uniformly expanded. There's a uniform expansion, there's a uniform thinning. These terms like uniform expansion, uniform thinning, hydraulic expansion, all lead us into thinking about a cystic lesion. So we're gonna go through these details a little bit more in depth in the next sections, but I want to focus on these terms right now: uniform expansion, uniform thinning, hydraulic expansion, which all can indicate a cystic growth.
We've just reviewed 2 cases, going through some data, a larger field of view to looking at like 21, 22. And then here we have a smaller field of view looking at that incisive canal and that tooth number 13. So let's go ahead and Dr. Bukhari, we're going to talk a little bit about analysis of the findings, talking about the borders, well-defined, ill-defined, and moving into that. So let's go ahead and do that now.
All right, so as Dr. Baclini mentioned, when we're analyzing a pathology, there are certain features that we can evaluate to help us conclude on what this pathology could be. Now, we may not be able to reach a definitive radiographic diagnosis in every case, but we can certainly narrow down the possibilities. Now, when looking at a pathology, we're typically analyzing the following: their borders, their density, the internal content, and its effect on the surrounding structures. Mentioning the shape can also help in some instances to describe a certain pathology. Some of them can be circular. Some pathologies may have irregular contours, and we'll come across some of these examples later on in the presentation. But let's take a dive into the first analysis, and that is borders. Now, we first want to know whether a border of a pathology is well-defined or ill-defined. To me, a well-defined border is something that you could possibly trace and easily know where the boundaries start or even end. Well-defined borders tend to occur in pathologies, as Dr. Polina mentioned, cysts, cystic lesions, some benign neoplasms, and even some fibro-osseous conditions, which we will come across later in the presentation. On the other hand, when we think of an ill-defined border, we can't really see it it can't be easily traced, or it kind of blends in with the adjacent structures, therefore making it difficult to either localize it where it starts or even ends. And some examples of ill-defined borders or pathologies that can show ill-defined borders are certain inflammatory processes or even malignant conditions. Now, when taking a look at this image on the slide, we can see that the borders of this entity in question are well defined, and we can see that it's formed a very hydraulic or circular shape. So again, I can easily trace the borders of this entity and localize it to a specific area. Here's a crop sagittal section on a cone beam CT section of a cone beam CT scan of the vertebrae. Now, when looking at the vertebral body of C2, we can note that there is a well-defined low-density area in the inferior portion of the vertebral body, and it's well-defined, and we can trace it to form a nice circular lesion. Here's another example of a crop sagittal section, or a crop section of the mandible, and a high density area noted apical to the first molar and second premolar regions. Now, the borders of this entity are slightly irregular, but nonetheless, they are well defined, and it can be traced throughout to show a well delineated entity. Now, when we take a look at this crop sagittal section of the mandibular left molar, there's a faint high density area noted in the periapical region of this distal root. Now, the entity appears to kind of blend in with the adjacent bone, and it's difficult to trace out where it actually ends or where it actually starts. And such ill-defined borders can be associated with inflammatory processes, such as rarefying osteitis or condensing osteitis. And these terms are synonymous with periapical pathologies of inflammatory origin, or in clinical terms, apical periodontitis. But the point is, when we're looking at this area, we can note that there is something going on, but the pattern of this pathology seems to be blending in with the adjacent bone. So therefore, the borders are ill-defined. Now, this is a coronal section of the mandibular rami. We see on the right side that the mandibular angle region exhibits an eroded cortex. Now, we can definitely see the extents of the erosion, but do we know where the pathology extends to once it has entered the soft tissue area? Or do we know if this is being caused by a soft tissue pathology invading into the mandibular angular region? Unfortunately, we can't do that or make this distinction on CBCT imaging. And such invasive types of borders may be seen in cases, again, of inflammatory origin or malignant conditions. And such erosive borders come under the umbrella term of ill-defined borders. Now, this is a crop portion of a panoramic image of the left posterior mandible. And we can see a large radiolucent area, but the borders appear to blend in with the adjacent alveolar bone. And we can also see that there's a breach in the cortex along the inferior border of the mandible. This is another example of a pathology with ill-defined borders, and our mind kind of goes towards a possibility of an inflammatory process or a possible malignant condition. Now, in radiographic terms, I think of cortication as like a response of the body to try and restrain a pathology, when in fact a cortical border actually refers to just an outer radiopaque layer, just like cortical bone. It's important, I think, at this time that the terms corticated and non-corticated be distinguished, and they're typically used to describe either low density or mixed density pathologies, but not really for high density pathologies. Certain inflammatory conditions or in fibroosseous pathologies, cystic pathologies, and benign neoplasms can show corticated borders, whereas non-corticated borders are typically seen in inflammatory processes, some fibroosseous conditions, and most of the malignant pathologies. Now let's take a look at the first image on the left side of the crop sagittal section of the left posterior mandible. We can appreciate a well-defined low-density entity that exhibits what I would consider a teardrop shape, and a thick high-density border can be noted surrounding the entity in question. So look at this very thick and very nicely high-density border surrounding the entity in questions, and this represents a cortical border or a well-defined cortex. Now that the definition of the pathology is significantly enhanced, the appearance of this pathology is significantly enhanced by this cortical border. Now, when we compare it to the image on the right side, we can see that there is a well-defined low-density area surrounding the apex of this premolar. But comparing it to the other side, we see that there is no well-defined cortex. So this is an example of a non-corticated pathology compared to a corticated pathology. This is a cropped axial section of the maxillary arch. So the arrow is pointing towards the area of interest, which is an oval-shaped entity with granular characteristics. Dr. Baglini will go into detail on the internal contents, but you can, when comparing it to the adjacent bone, it seems kind of granular. And the peripheries of this entity in question, number one, tend to kind of blend in. And not only that, there's no cortical border or no radiopaque border or high density border that surrounds this. So this is an example of a non-corticated pathology. Now, scalloping is a term that's used to describe a certain action of a pathology, and it's associated with the borders. So pathology can actually scallop between roots or along the endosteal surfaces of the borders. And scalloping, as we know, is kind of like a wavy form of a boundary. And so when we're looking at this cropped sagittal section of the posterior mandible, the arrows point to the borders of this low density area, which are scalloping between the roots of the mandibular molars. Now, such features can be associated with pathologies such as simple bone cysts, ameloblastomas, or even odontogenic keratocysts. So this is a type of action that occurs that's associated with the borders of certain pathologies.
So in this section, we're going to talk about the density and the internal content. So pathologies usually can have multiple densities. They can be homogeneously in the internal content. They can have only a low density, internal density, and which we can also call radiolucent. They can be homogeneous and high density, which we call also radiopaque, or they can have a mixed density internal content. So this case has a low density osteolytic lesion, pericoronal to number 1. So here we have a coronal, a sagittal, an axial, and a 3D rendering views of a pericoronal homogeneously low density lesion on number 1. And this is actually myself. This was biopsied as an odontogenic keratocyst. So I'm just going to talk a little bit about also the behavior of this lesion very briefly, because we're going to do that later in the other sections. So we have a homogeneous low density lesion. You see how there is like a balloon expansion, just as we mentioned before. There's thinning of the cortices, uniform again, and thinning and expansion. On to the next case, we have bilateral low density lesions in the posterior mandible. Here we have the right mandible, coronal, sagittal, axial, and 3D rendering views, and here is the left mandible. These lesions are also homogeneous in their internal content. There is only low density in the internal content. We don't see anything else. Now onto the high density lesions. We have a homogeneous lesion that only has high density, cortical density entity, and it's localized on the medial aspect of the right ramus here. So this is an osteoma. We don't see any internal low density areas. This is a case in the left mandible where we have an area of increased density. And this is a case of idiopathic osteosclerosis or dense bone island. And as its name mentions, it's a denser bone and hypovascularized bone. Usually these lesions do not tend to have any effects on the surrounding structures, except for in rare cases where they can cause some expansion, some root resorption, or they can impede on the eruption of certain teeth, but again, in very rare cases.
And I think it shows, if you can go back to that last slide, it shows exactly what we were talking about on that mesial root of that molar, how it does not look like it's impinging on that.
Exactly. We can even trace the PDL spaces, and everything looks intact in that area.
Right.
Yeah. This is a lesion in the right posterior maxilla. We can see, as Dr. Bukhari mentioned before, a granular density. It has a homogeneous granular density, and it blends in with the surrounding bone. This is a fibroosseous lesion, which is a fibrous dysplasia. And I just have to mention here that fibrous dysplasias do not always have this internal content, because they actually go through phases. In the early phases, you can see a low density component within the lesion, and that's because they're more active. And as they tend to mature, they tend to have like a homogeneous granular density. This is a case in the on the right mandible around number 28. We can see again a corticated lesion, as Dr. Bukhari mentioned before, a corticated lesion with internal homogeneous content. We have granular density and we have some lower density areas. Now, this low density area here is where they actually biopsied. This lesion also is circular and has like a circular manner of expansion. And this is an example of also a fibroosseous lesion, which is an ossifying fibroma. Now, an ossifying fibroma can also vary in the internal content. But this is like a typical way of growth of the ossifying fibroma. It tends to grow in like a more circular manner than fibrous dysplasia.
You can even see that rendered on that 3D rendering there on the lower right.
Yes, and you can see it here also on the sagittal view. This is a case of also a fibroosseous lesion. This is 23, 24, 25, and 26. We have mixed density lesions composed of high density entities surrounded with lower density areas and some even granular density areas. So this is a cemento-osseous dysplasia, periapical cemento-osseous dysplasia in this case. We are also going to talk about the effects on the surrounding structures in the next section. I just wanted to show how mixed density lesions can really vary in how they look. They don't have a typical way of having, the internal content. Some of them have granular densities, some of them have only low and high density entities. They can really differ. And this here is another example of a different type of mixed density lesions. Here we can really appreciate coarse and thick septations that are really irregular. This case is, we're going to talk about it also in the next section, how it's behaving. But I really wanted to show the difference in the internal densities here. We have coarse septations and areas of low density, as opposed to this case, which is also a multilocular lesion. But we can see how the septations are thin and faint, as opposed to the previous case. This is also here a septation. So this shows how various mixed density lesions can look. Now, in the next section, we're going to talk about the effects on the surrounding structures. So this is the same previous case. Those are the sagittal and coronal views that I already showed, showing the septations. On this axial view right here, I pointed out how the lesion is causing non-uniform expansion here of the buccal cortex with non-uniform thinning, and also expansion, thinning, and possibly interruption of the lingual cortex right here. So when we talk about non-uniform thinning, non-uniform expansion, we usually think of a neoplastic process. Usually when a lesion causes expansion, has time to grow, and causes non-uniform expansion, is usually a benign neoplasm. And on this cropped sagittal view, we can see also how it's causing inferior displacement of the left mandibular canal towards the mandibular cortex. Also, it's important to emphasize that when a lesion has time to displace structures, it's usually a benign process, usually. Because when it's malignant, it tends to like destruct, interrupt, cause root resorption, like a ragged destruction of the borders. And on this axial view, we can also appreciate root resorption on number 18 and 19. So you see how different views gave us different information. Hence the importance of looking at all these different views when analyzing a pathology. Now, back to the periapical cemento-osseous dysplasia case. We can also appreciate how it's causing thinning of the cortices. Sometimes it can cause interruption, sometimes expansion as well. However, rarely in these cases of cemento-osseous dysplasia that we see root resorption. And I would like to highlight the importance of analyzing the scan when we get it, because these entities do not really require any biopsy. They have characteristical features that would confirm the diagnosis, because biopsying these lesions may increase the risk of their infection. So there's no need to biopsy cemento-osseous dysplasia lesions. And we usually recommend follow-up, especially in the cases where there's interruption of the cortices, just to ascertain stability and make sure that there's no infection involved. Now back to this case right here. Let's analyze a little bit the behavior of this lesion. So we do see coarse septations, but we also see periosteal bone reaction, like in a spiculated manner. Now, periosteal bone reaction, we can see it in various lesions. It can be inflammatory, it can be malignant, or it can be, maybe in this case, maybe a hemangioma. But usually when it's spiculated, we think about either a malignant lesion or maybe a hemangioma. Now, in this case, when you look at the effect on the surrounding structures, it's causing displacement of teeth. 30, 31, and 32 are displaced. The mandibular canal is displaced. There is expansion in the cortices. This is why in our process, we were leaning more towards a benign lesion, maybe a hemangioma. However, I don't have a final biopsy on this case or a final diagnosis. We recommended advanced imaging because, a hemangioma, you would rather not biopsy and cause hemorrhage. However, we did not get a final diagnosis on this case, but this was the thought process. We were thinking more about a benign process because of the way the lesion was behaving. We didn't see really destruction of the mandibular canal or root resorption. We only saw displacements and growth. So, and by the way, the clinical information that was provided is that the lesion was there for a long time, which also maybe confirms that this is a benign process and it's slow growing.
And that's part of the importance of having patient history whenever you get a radiology report of,
Absolutely.
What history do we have? Knowing that patient history is very important.
Oh, yes. We always appreciate as much information as possible. Now, in this case, this is a cropped panoramic reconstruction. We have two low-density areas between number 26, 27, and 28. So on this slide, we have multi-planar reconstruction views of the lesion between 26 and 27. We have a homogeneously low-density lesion that is causing thinning, interruption of the cortices, that is ovoid in shape, that is causing interruption of the lamina dura on number 26 and 27. And then the next slide is the lesion between number 27 and 28, which is also a low-density lesion causing thinning, interruption of the buccal cortex, interruption of the lamina dura also on the adjacent teeth. And this was a case of lateral periodontal cysts between 26, 27, and 27, 28.
Dr. Bakar, you're going to take us also through a couple of images here and go through some items.
Yes. So so this is basically we have an axial section of the right side of the mandible, and this was a patient who came in actually for routine follow-up, and the referring provider actually noted that there was a swelling on the right side and on the lingual aspect of the mandible. So he took further imaging because the soft tissues actually seemed a little, he mentioned, wonky. And so when scrolling through the scan, I noticed that, you know, there was interruption of the lingual cortical plate adjacent to the the second premolar and the first molar. Now, again, this is, you know, we can define this as ill-defined entity and invasive borders, causing basically interruption of the lingual cortical plate. There could have been a mandibular tori on the side. We're not sure. That could have been eroded, but our mind immediately goes towards the possibility of a localized inflammatory process or a malignancy that's causing destruction of the lingual cortical plate. Now, this is actually another case where the patient was having clinical signs and symptoms on the left side of the mandible. Now, in this image, we can see bilaterally that there are extensive tori on the lingual aspects, but the more posterior tori on the left side, it shows irregular borders, in fact, eroded borders. And then in a slice, when I was going through a specific slice, I noticed an isolated fragment just in this soft tissue region of the eroded bone. This could have been an isolated bone fragment or a sequestrum, and such findings can be associated with osteomyelitis. However, in such cases, you want to make sure that, you know, that's followed up with a biopsy and maybe even further advanced imaging for a definitive diagnosis to distinguish between an osteomyelitis or even a localized malignant process. But nonetheless, we have ill-defined evasive borders that are affecting the mandible in this case. Now, I'm also going to take you through a couple of cases on CBCT software to show some more pathologies, their specific analysis, as well as the effects on surrounding structures. Well, we're going to go through a case on the CBCT scan. Now, the first and foremost thing I'm going to do is go through the volume to try and detect the area of interest. And as I'm scrolling around, immediately I notice that the area of interest is in the left mandible. Now, as Dr. Bucklini mentioned before, you know, it's always good to orient yourself. So what I'm going to do is I'm going to take these indicator lines and orient along the path of the pathology. It gives you a much clearer view of the pathology and its actual effects on the adjacent structures. So I'm going to take these indicator lines and just move along the path so that these lines are just parallel to the area of interest. And I tend to get rid of these, the indicator lines, just so that we have no hindrance in the path of the pathology that we are interpreting. So we can see the area of interest again is the left posterior mandibular body in ramus, and we see a homogeneously low density entity, which is extending from the superior portion of the mandibular ramus all the way to the periapical regions of tooth number 18. Looking at it in the coronal and axial sections while scrolling through, we can see that there are features of thinning and expansion of the cortical borders. But I do want to mention something, and that is when we are comparing, or we're thinking about the size of the pathology in the long axis right now, comparatively, there's minimal expansion noted along the buccal and cortical plates. So this actually, one of the features of odontogenic keratocysts is that as they move along, they tend to move along the bone, and they can cause minimal expansion. In some cases, we may see more expansion than usual, but they tend to grow along the bone. And this was actually a case of a odontogenic keratocyst in the left posterior mandible. We can see in this sagittal section right here, a faint outline of the mandibular canal or the inferior alveolar nerve canal, and it's been the superior cortex has been thinned and slightly displaced towards the inferior aspect. The lamina dura and the periodontal ligament space can't be discerned on this distal aspect of the tooth. So taking into account the definition, we have a well-defined low-density area. We mentioned where it's extending from, its effect on the surrounding structures, thinning and mild expansion, displacement of the nerve canal. And, we can come to a conclusion that this is more on the lines of a benign neoplastic, maybe even a very rare cystic lesion. But in this case, this was most likely a case of an odontogenic keratocyst. And I'm going to show another case, which we actually went through Dr. Biccolini actually went through in the images. So I reset the scan at this time, and I'm going to scroll through one slice or a couple of slices just to see where our area of interest is. And immediately we can see that the left posterior maxilla is our area of interest. So I'm going to move the cursors here to the area of interest and try and orient myself along the path of the pathology. Now it's time to scroll through. So again, we can see a well-delineated area in the left posterior maxilla where the internal contents of this area of interest is granular. Now, this is a great case to show granular internal content, as mentioned by Dr. Biccolini before. And the entity is actually extending from the posterior aspect of the maxillary arch all the way to the periapical regions of the premolars, then extending from the crestal level of the alveolar bone in the left posterior maxilla all the way to the floor of the left maxillary sinus and the floor of the nasal cavity on the left side. And as a result, we can see that there's significant elevation of the left maxillary sinus to the point where it's reduced the maxillary sinus volume. In the axial section, we can also see that there's significant expansion of the buccal and ligmocortical plates. And we can really appreciate the granular and near homogeneous appearance of the granular internal content. This was a case of likely fibrous dysplasia in the left posterior maxilla. And as mentioned before, mixed or fibroosseous lesions, we have to be careful in terms of when and when not to biopsy, because if we're already these entities tend to affect the bone already by hypovascularization, and when we try to take a biopsy in such cases, there could be a chance of secondary infection. So we really need to know when and when not to biopsy a certain condition. Fibrous dysplasia, periapical cemento-osseous dysplasia, we tend not to do biopsy these. But in the case of ossifying fibromas, because it acts like a neoplasm, even though it's a fibroosseous condition, there are certain limits. So it's important to know the differences.
That axial slice is a great example of looking, when you do your comparison right to left, contralateral, just a general overview of what are we seeing when you do identify some of these pathologies from an initial standpoint of, really goes back to the first session we had of how do we look at these, just top, bottom, front, back, or inferior, superior. That's going to show us that difference on there.
Absolutely. And so why it's so important to try and orient yourselves as well so you can compare both sides equally.
Dr. Bakari, thank you for taking us through those cases. I think now we're going to look at, we've went through all these different shapes, borders, and defining things, but what is the impression of exactly what we're seeing? So you're going to kind of take us into that.
Absolutely. So now me and Dr. Biccolini want to take all this information that we presented and put them together to form an impression. Now we will take this example right here on the image on the slide. And when looking at this entity, what I see is a well-defined, corticated, ovoid-shaped, and low-density lesion noted in the left posterior mandible, closely associated with the roots of number 18. Now, it may not be, apparent on this image, but during when I was looking at this case, there was inferior displacement of the mandibular canal. Now, keeping these features in mind, I can postulate in my mind that this is likely representative of a cystic lesion. And please note that some benign neoplasm can show cystic properties, but that's for another topic at another time.
So Dr. Boccolini, you're going to actually take us through a radiology report / read on one of these cases and kind of go over findings all the way through impressions and some image examples on there.
Okay, so I'm gonna just explain a little bit about the different sections in this report. The first section has all the patient information with the doctor's note and the areas of interest. In the acquisition method is where we kind of describe the extension of the CBCT. We talk a little bit about the radiographic technique, if there are any artifacts, impeding on the interpretation, or any technique errors. We just mentioned them in this section. Now, in the next section, the radiographic findings is where we actually describe any findings that we think can be associated with the lesions or pathologies. And in the final section is where we kind of give our impressions or our differential diagnosis. Now, in this case, I'm going to start showing the screenshots to explain a little bit. This is a panoramic reconstruction. We can see multiple areas of, mixed densities. And as I'm scrolling, I'm going to show some of the cross-sectionals here. This is number 17. We have a coronal, sagittal, axial, and 3D rendering views. Now, it's partially visualized, but there's clearly a low-density lesion surrounding the visualized part of the apex, which is causing some expansion, some thinning of the cortex here. On number 19, we also have a mixed-density lesion composed of a homogeneous low-density area here and a granular density area at the level of the furcation and periapical to the mesial root. It's also causing expansion of the buccal cortex. On number 24 and 25, we have homogeneously low-density lesions that really look like periapical lesions. However, we're going to talk about this in the impressions. Number 30 also has a mixed density area, a high-density entity here, some granular and low-density areas that's causing thinning of the buccal cortex. The same on number 32, which is partially visualized. We have a high-density entity surrounded with a low-density area. Now, I'm going to go to the impressions and talk a little bit about the case here. So I combined 17, 19, 24, 25, 30, and 32 as suggestive of having florid cementoosseous dysplasia. I am sure that it's cementoosseous dysplasia, but number 24 and 25, since they have low density areas which are homogeneous, we need to rule out the possibility of a periapical lesion of endodontic or inflammatory origin. So this is why I use the word suggestive, because sometimes we do see cases where they try to do endodontic treatment on these teeth, which are really vital and do not need any intervention, just some follow-up. Because in the early stages of periapical cementoosseous dysplasia, just as I mentioned before, they can really typically look like a periapical inflammatory lesion. So it's really important to, clinically diagnose, do the vitality testing and all of that to be able to rule out any endodontic origin.
I definitely agree. I think it's very vital that it's important to remember that, there's so much that we can deduce on radiographic interpretation. I think it goes hand in hand with clinical information. You can't do one without the other. But if we find something radiographically, it's important to correlate it clinically as well, so we can come to a diagnosis.
Absolutely, I agree.
I want to thank everyone for attending today, your interaction with us. Dr. Boccolini, Dr. Bukhari. We covered a lot of material. I think we touched on a lot of the objectives, including, understanding, interpreting artifacts. We talked about motion and beam hardening. We should have gained some proficiency in examining lesions from all different dimensions. I think both of you took us through those. Talked about describing borders, density, internal content, a lot of terminology, analyzing the patterns of bones and understanding the impact on surrounding structures. Dr. Boccolini, you took us through some cases to show that and some screenshots, and Dr. Bukhari, you did the same thing. And then the radiology review and best practices of what we're seeing and what we can expect from the objectives and learning on there. So I want to thank you both for the time. Beam Readers and Mr. Barney Gill, thank you for the partnership here and allowing me to be the moderator and Vatech supporting this session.
Thank you so much for having us.
Thank you so much to both of you.
Yes, and I look forward to our next session coming up in about a month.
Sounds
Looking
good.
forward.
Gotcha. Have a great afternoon, everyone. Thank you.
Take care.
Thank you again, Drs. Boccolini, Bukhari, Jim Mayer, and all who joined us today. We hope this enhanced your personal tool set for evaluating your CBCT scans, helped provide criteria for when to consult an oral radiologist for a second opinion, and a glimpse into the expertise applied to every scan read at Beam Readers. Be looking for that survey email to ensure you get your CE credit for today. To continue on your personal education journey and dive deeper into 3D knowledge, please come give us a try by submitting a patient CBCT scan at www.beamreaders.com. Thanks and have a great day and weekend, everybody.